Adaptation to the extrauterine life.
Okay, all right. That's a very, very important topic. I think as long as you understand what happens, then you may understand lots of things that's going to happen to neonates. Okay, all right. Why can't I go there? Okay, I hope you can see. Can you see my screen? Okay, all right. Can you see?
Yes. Yes, we can.
All right. So the topic that's given to me is birth asphyxia. So this is what we are going to discuss this morning. It will not be long. Don't worry. Sessions with me usually it's gonna be just for around 1 hour. It shouldn't be longer than that. And this is quite a simple topic lah, which I'm not going to go in great detail. Okay. All right. So. Hmm. The objectives is basically for you to understand the keywords important in regards to birth asphyxia, and then for you to know the causes and risk factors for babies to develop birth asphyxia, learn the pathophysiology involved, learn the presentations and complications of asphyxia, and learn some of the managements for babies who are born with perinatal asphyxia. Introduction. So the definition, what is the definition? So perinatal asphyxia is a condition of impaired gaseous exchange where there is inadequate blood flow, so there's impaired perfusion that leads to persistent hypoxemia, low oxygen in your blood, and hypercarbia, high CO2, high PaCO2 that occurs in the temporal proximity to labor, which is meaning is peripartum. It can be intrapartum, it can be just the period antenatal, and it can also be the period just postpartum. So basically, birth asphyxia, perinatal asphyxia is a perinatal period where just before delivery, during delivery, which is intrapartum, and postpartum, just after delivery, and this may result in whatever condition that causes impairment in blood supply, whatever condition that causes impairment, reduced perfusion to organ system to the baby, and this may result in perinatal asphyxia. Hypoxemia, I think you should know, is a low blood oxygen level. Hypoxia is low oxygen level in the tissue level. Ischemia is basically reduction or complete cessation of blood flow to an organ, and it may result in necrosis and so on and so forth. HIE or neonatal encephalopathy. HIE is hypoxic ischemic encephalopathy. Yeah? So neonatal encephalopathy is a clinical syndrome of disturbed neurological function. So there's some disturbance in the neurological functioning of the baby. What is the cause? Caused by failure to make successful transition to extrauterine gas exchange. So you've learned before just now with Dr. Taufik what happens from the in utero to extrauterine life, the difference in changes in the oxygen level, in the PaO2 and PaCO2 level, and what are the changes happening when they cut the cord, and so on and so forth. Okay, so how does it manifest? It manifests difficulty initiating and maintaining spontaneous breathing. You can see poor muscle tone, poor reflexes, altered conscious level, and seizures as well, and comatose. Hypoxic ischemic encephalopathy is encephalopathy that manifests following again impairment in cerebral blood flow and hypoxic ischemia of the brain in term and near term infants. And basically, perinatal refers to intrapartum hypoxic ischemic insult that leads to fetal hypoxemia, hypercarbia, and acidosis. So basically, when you have hypoxemia, you have hypercarbia, your body can't go what we call that aerobic metabolism. You'll go to anaerobic. The product of this, if you remember, the product will be lactic acid. So lactic acid. So that's why you may have high lactate in this sort of babies. Okay, moderate or severe neonatal encephalopathy occurs in 1,000 live birth, usually affects full-term infant. Basically, neonatal encephalopathy refers to hypoxic ischemic encephalopathy. And other causes for neonatal encephalopathy, so neonatal encephalopathy is a big topic. Under it, majority is HIE. Majority is HIE, hypoxic ischemic encephalopathy. But there are other causes for neonatal encephalopathy, such as CNS malformation, intracranial hemorrhage, intracranial infections, such as, for example, the one we've seen before are dengue encephalitis. And I've seen a mother who's had dengue uh, just few days before birth, and the baby had dengue encephalitis, congenital dengue, causing pneumonitis, encephalitis, and so on and so forth. We've seen babies with varicella, chickenpox, varicella encephalitis, very, very bad. We've seen babies with, what else? Uh, so dengue encephalitis, varicella encephalitis are among the things that I think we see quite frequently. And then cerebral infarction, stroke, or again, babies can get infarction and stroke, metabolic disorders, drug toxicity, drug withdrawal, electrolyte imbalances, and seizure disorders. Because when you have seizures, there may be impairment in blood supply, especially to the essential organs such as the brain. So risk factor for neonatal encephalopathy were mainly seen in antenatal period as compared to intrapartum period. So because mainly the result is the problem happens just before the delivery. What is the pathophysiology? So basically, the main event is there is prolonged hypoxia, prolonged reduced oxygen, and this results in ischemia, acidosis, and this results in cell death and organ damage. So the mechanism of neuronal injury. So there's primary phase where there's initial insult, the initial insult, the hypoxia causes energy failure. So because why? Your body won't produce adequate energy without oxygen. So result of energy depletion is failure of sodium and potassium pumps, leading to depolarization of the membrane of the neurons. And this depolarization, what it does, it causes the neuron to release excitatory neurotransmitters such as glutamate into the synaptic cleft. This causes the excitotoxicity. Excitotoxicity causes the baby to be sometimes initially hyper alert, and then the baby may become encephalopathic, seizures, and so on and so forth. So this leads to overactivation of glutamate receptors, causing passive influx of chloride and sodium into the neurons, causing osmotic edema and rapid cell death as well. So additionally, the glutamate receptor activation causes a massive influx of calcium into the neurons. You know, calcium is among the important electrolytes that causes the uh, uh, excitatory of the your action potential. Okay, all right. So this, and then the secondary phase or delayed phase. So basically, free radicals are formed, lactic acid are formed. So this lactic acid form can get through cell membranes and can damage not only neurons, the glial, and also the mesenchymal cells as well. So lactic acid and hydrogen ion can cause cerebral edema by absorbing or attracting water to them. So these are the events. So primary energy failure causes sodium overload and excitotoxicity by the chloride as well. And then with reperfusion, there will be calcium overload. And then this NO is nitric oxide. And then secondary phase after 6 hours is mitochondrial dysfunction and caspase activation. By how? By lactic acid and so on and so forth. So the intervention to actually reduce the risk of injury, we need to do it within the 6 hours before the secondary phase has occurred. Before the secondary phase has occurred. So again, cellular, what are the mechanism of the injury? If you look at the cells, so basically there's cellular injury or death initially by the primary phase. How? By failure of the ATP dependent pumps. Why? Again, as mentioned before, because of the chloride and also the sodium and excitatory amino acid receptors overactivation. So they are overactivated. They are easily excitable. Release of glutamate and activation of the glutamate receptors, overactivation of the glutamate receptors, and influx of sodium and calcium afterwards into the cell, which causes cytotoxic edema. And this may result in cell apoptosis, cell death. And then secondary phase are the apoptosis and tissue injury, which are the delayed secondary phase. What happens is activation of the catabolic enzyme such as proteases, phospholipases, endonucleases, caspases, production of nitric oxide, release of oxygen free radicals. So these are all oxygen free radicals are injurious to the cell as well. It damages the cell and causes apoptosis. So, what are the risk factors? So, which babies, which condition has higher risk factors to develop asphyxia? So, there are multiple maternal, placental, fetal, intrapartum causes. So, maternal, we can see preconception factors, including maternal unemployment, family history of seizures, neurological disorders, infertility treatment, maternal thyroid disease as well, placenta with severe preeclampsia, post-date baby because of placenta insufficiency, and abnormal appearance of the placenta where you can see calcification and so on and so forth. Fetal causes intrauterine growth restriction because of placenta insufficiency. Intrapartum persistent also risk factor for especially fetal is actually twin specifically monochorionic MCMA twin, monochorionic monoamniotic twins are the most at risk. There's so many problems with monochorionic multiple pregnancies. Now you can have twin to twin transfusion, you can have anemia syndrome, you can have so many problems with TAPS. TAPS is the anemia syndrome with multiple pregnancies. And the intrapartum, such as persistent occipito-posterior, persistent position of the baby, where there's difficulty in delivery and causing impaired blood supply to the baby as well. Shoulder dystocia, again, difficult delivery. Emergency cesarean delivery, sometimes it may be difficult as well. Because sometimes before they go for emergency cesarean, they already attempted, they will prolong second stage, fail vacuum, fail instrumental delivery, and so on and so forth. Operative vaginal delivery, which also is a very difficult delivery, so there may be period where there is impact perfusion, the cord may be entangled, yeah, and so on and so forth. So acute intrapartum events such as uterine rupture. I've seen babies who when they go for cesarean section, there's already uterine rupture. The baby is already out of the uterus. The baby was born in very poor condition, and basically was severe HIE from the very beginning. And baby died, I think, after 5 months with so many issues as well. And then placenta abruption, cord prolapse. Again, cord prolapse is another scary event where the cord already comes out and you need to protect the cord, because without the cord, the baby will be hypoxic. Yeah? And then tight nuchal cord, maternal shock or death of the mother as well, and inflammatory events such as maternal fever, chorioamnitis, prolonged rupture of membrane, and all this can result in impaired perfusion to the baby. Causes. So viral disorders in the mother, inadequate oxygenation of maternal blood, because hypoventilation. If mother is under GA, for example, there may be there's a risk of the baby having hypoxic insult, and then cyanotic heart disease of the mother as well is another risk. Mothers having respiratory failure, carbon monoxide poisoning. You remember there are conditions where the mother, for example, I think in Sungai Buloh recently, probably early last week, we have a mother who has stage 4 COVID in our hospital in Malaysia. Mother had stage 4 COVID and the baby was born by cesarean section. So this is another risk factor when the mother has problem with respiratory issues. So low maternal blood pressure because of acute blood loss, whatever cause of the hemorrhage, vehicle accident, for example, spinal anesthesia, compression in the vena cava of aorta by the gravid uterus, because sometimes the huge gravid uterus can compress maternal blood supply, and this causes reduced blood supply from the mother into the placenta. And uterine tetany, for example, is another cause. Premature separation of the placenta, abruptio placenta, impedance to the circulation of blood through umbilical cord because of knotting of the cord placenta insufficiency, maternal infection, torches, for example, diabetes, toxemia, or post-maturity, and IUGR as well. How do we diagnose neonatal encephalopathy? So, how do we diagnose hypoxic ischemic encephalopathy? This is the criteria. So, first there's 1 and 2 and 3. So, early onset of moderate or severe encephalopathy in newborn. So, more than 35 week gestation age. Sometimes if we have the EEG, we may see some EEG changes. And so the baby should have 3 of the signs. So number 2 is neonatal signs consistent with intrapartum or peripartum event. Apa dia? For example, arterial cord pH of less than 7.0, Apgar score of less than 5 at 5 minutes, and less than 10 and less than 5 at 10 minutes of life. Evidence of multi-organ system dysfunction within 72 hours of birth. We may see either renal impairment, liver impairment, or whatever problem with the organ system. Elevated cardiac enzyme, for example. And then neuroimaging evidence of acute brain injury seen on MRI brain. Usually we do the MRI brain after 1 week. We may see some changes that are consistent with hypoxic ischemic event. And then time and timing of contributing factors that are consistent with intrapartum timing. Contohnya sentinel hypoxic or ischemic event. So we noted that there are events during labor or during the delivery. Fetal heart rate pattern maknanya abnormal, dia jadi sinusoidal, for example, or there's no acceleration, very poor beat to beat variability, and these are all signs of fetal punya fetal hypoxia. And the third one is the absence of an infectious cause, a congenital malformation of the brain, or an inborn error of metabolism, or any other condition that can explain the encephalopathy. So this is where we diagnose the baby to have hypoxic ischemic encephalopathy. Why do we a bit strict in terms of diagnosis? Because when we label a baby with hypoxic ischemic encephalopathy, we are basically blaming the perinatal asphyxia, birth asphyxia, and there are lots of medical legal issues related to this. So that is why we need to make the diagnosis very, very clear and very, very strict. So how do they present? The initial physiologic response to pregnancy is redistribution of blood flow to from the non-vital organs. So when the when the fetus noted that there is impaired blood supply, so the baby's own physiological response is to shunt blood from non-vital organs into the more vital organ, which is the brain and the heart. So what happens is the eyes, kidney, gut, the bowel, the liver, all this may be dysfunction. So what are the organ dysfunction in HIE? So first, brain. So brain, again, because of encephalopathy, even though the body tries to save the brain, but the brain is affected. That is why the baby develops encephalopathy. So in the delivery room, what we may see at birth, the infant will often exhibit low Apgar score, the scoring how we do to assess a baby's condition at birth. They may be weak or absent cry. Almost all of them may need some resuscitation, which you will discuss. You will learn about how we resuscitate newborns tomorrow. So infant with encephalopathy, they have abnormal state of conscious level. So at the most mild, they are hyper alert. Hyper alert ni maknanya baru-baru lahir je, baby tu dah mata dah buka, terbeliak besar. They are hyper alert. They are looking at their surroundings. Usually at birth, after birth, the baby is a bit less active, and then they become more and more active by day. But babies with mild form of hypoxic ischemic encephalopathy, they are hyper alert at birth. They may be irritable, and then they become lethargic or obtunded, comatose. And they may be diminished spontaneous movement. They don't move much. They are flat at birth. They have respiratory or feeding difficulty. They have poor respiratory effort, and they have poor sucking, poor swallowing, poor tone of the muscle, abnormal posture, absent primitive reflexes. Again, we'll learn about primitive reflexes when you do neonatal examination later, and they may have seizures as well. So you can classify encephalopathy using 2 scores, either Sarnat and Sarnat or Thomson scoring. So this is the SANAT scoring, modified SANAT classification. So we classify according to level of consciousness, muscle tone, reflexes, sucking, Morose reflex, seizures, and these are the prognosis. So mild, the baby is hyper alert. Moderate is the baby seems to be lethargic, and severe, the baby is stuporous or comatose. Muscle tone may be normal or slightly hypotonia in mild. Moderate is HIE, and severe, the baby is flat, flaccid. And in mild, they have normal or poor sucking. Morose may be exaggerated. In moderate, weak or absent or incomplete sucking and moro. And in severe, both are absent. Seizures, you won't see seizures at mild. The moment the child has seizures, it should be classified as moderate HIE. And in severe HIE, the child is maybe comatose. The child may not have seizure, but if the child had seizure, the seizure may be very frequent and very difficult to control. In terms of prognosis, prognostication-wise, mild HIE are good prognosis. They usually recover within the first 24 hours. Moderate HIE prognosis may be abnormal. There may be some element of neurological sequelae, but in severe HIE, the babies are usually severely abnormal. And many of them actually leads to early neonatal death. Even if they survive, they are severely handicapped. So prognosis-wise, it is extremely bad in babies with severe HIE. And this is another scoring that we do. Thomson encephalopathy score usually we do for cooling, how to initiate cooling, and also while doing the cooling therapy. I'll tell you what is the cooling therapy later on. So we look at the tone, loss of the conscious level, seizures, posture, Morose reflex, grasp, suck, respiration, and fontanelle. So we classify 0, 1, 2, 3, and then we give the scoring. The higher the number, the worse is the condition of the baby. Okay, so that is the first organ dysfunction that we discussed. The second is respiratory system. So which is seen in 71 to 86% of babies with HIE. So it's frequently seen, usually result of underlying concomitant disorders. They may have sepsis, pneumonia, MAS, and so on and so forth. And perinatal asphyxia is associated with persistent hypertension of the newborn, because when you have PPHN, your arterial oxygen is arterial blood is not well oxygenated, and this may result in hypoxemia. Infant with respiratory failure may require intubation and mechanical ventilation. Infant with hypothermia also are typically intubated and mechanically ventilated. Why? Because when they are cooled, and we start the cooling. So cooling therapy is basically where we reduce the body temperature of the baby. So normal human body temperature is 36.5 to 37.5. That's normal body temperature. So in this sort of baby, we reduce the temperature to 33 to 35 degrees Celsius. So what happens is when we reduce the temperature, then we vasoconstriction, we basically we prevent the body from going into the secondary or delayed injury where there's cellular apoptosis and so on and so forth. So this is what we do. But when we hypothermia, when we cool the baby, when we put the baby into hypothermia, many of them sometimes they may have reduced tolerance in terms of breathing. They may be reduced respiratory effort and so on and so forth. In 43 to 78% of children with HIE, they may have cardiovascular insult. So what happens is reduced cardiac output and hypotension due to impaired myocardial contractility due to myocardial ischemia. So blood supply to the cardiac is reduced. And ischemic effects on the cardiovascular system are detected by blood pressure measurement. You can see the baby may have hypotension because of reduced cardiac output. So cardiac output equals to stroke volume times heart rate. And blood pressure is cardiac output times total peripheral resistance. Okay, so how we assess myocardial function, basically among the a proper way for us to assess is do echo. So we may see ventricular dysfunction, poor contractility, And we can see PPHN as well. We can see TR. If babies have PPHN, we can see TR, tricuspid regurgitation. And then if we do ECG, which is not easy in newborn babies, we may see ST depression, T wave inversion, and if we send blood, we may see elevated cardiac enzymes. In 46 to 70% may have renal involvement, where the baby may have oliguria initially, and then why oliguria? Because reduced cardiac output. So reduced cardiac output, reduced renal perfusion, reduced GFR as well. So maybe reduced urine output. And so that's why we need to monitor the serum creatinine and electrolytes, and management will depend on the severity of the renal impairment. The thing is, renal impairment in newborn babies are difficult to manage. Why? So in bigger babies, in bigger children, we may go for like hemodialysis and so on and so forth. But for newborn babies, it's very difficult for you to do hemodialysis. Why? Because the volume of blood that they have is very small. For example, the total blood volume that you have is only 80 mils per kilo. If the baby is 1 kilo baby, the volume of total blood the baby has is actually around 80 mils only. 80 mils. 80 mils ni is less than 2 ounces. Kalau botol susu tu less than 2 ounce. 1 ounce is 30 mils. So sikit je blood volume dia. So can you imagine if you do hemodialysis, you need how many mils of blood inside the tubing itself? So if you do hemodialysis, probably up to 40-50% of blood is actually just in the tubing. Belum dalam machine lagi. So it's very difficult. And then sometimes if you want to do like, I've had one baby which we do peritoneal dialysis. Again, peritoneal dialysis in newborn babies are difficult. It's not easy. It's not easy at all. So if the baby has renal impairment, sometimes it may, the result is very significant. 80 to 86% of them may have hepatic injury, liver impairment. You can see elevation of liver enzymes such as ALT, elevated ALTs, elevated gamma GT, elevated AST, and so on and so forth. So decreased liver function result in hyperbilirubinemia, hypoalbuminemia, coagulopathy, and the bleeding, bruising, and it also affects pharmacokinetics of drugs that rely on hepatic metabolism. For example, what? For example, almost all, basically all of the anti-epileptic drugs. The babies with HIE, they have seizures, but then it's very difficult for you to give anti-epileptic drugs because all anti-epileptic drugs are metabolized by the liver. So it's very difficult for you to achieve proper level. For example, they may be more hepatotoxic. So long-term effects of neonatal liver hypoxic ischemia are unknown because many of them actually don't survive. GI tract. So GI tract, reduced tolerance to enteral feedings. Why? Because there may be impairment in terms of the mesenteric artery. So mesenteric artery supplies to the bowel. So if there is impairment, so the bowel may not be moving really well. So reduced peristalsis. So bila reduced peristalsis, maybe a problem with feeding issues. They may be vomiting, do not pass PO, partial intestinal obstruction, and then it may also result in NEC, necrotizing enterocolitis as well, because of impairment in blood supply, overgrowth of certain bacteria, and so on and so forth. Hematological cause in 32 to 54%. What are the results? We can see impaired coagulation, thrombocytopenia. Why? Because DIVC. I think a few weeks ago we have one baby with HIE and has DIVC with severe coagulopathy, severe thrombocytopenia as well. And also because of impairment in blood supply, it suppresses the bone marrow function, impact hepatic production of clotting factor, that's why coagulopathy, increase in bleeding time and endothelial dysfunction. So all this may result in lots of problems with bleeding and so on and so forth. Another thing is glucose metabolism. You remember as well, glucose metabolism is dependent on the oxygen. So initial stress-induced hyperglycemia is followed by a sharp drop in blood glucose level due to increased glucose consumption. And then hypoglycemia is also more common in infants with severe liver damage due to inadequate glycolysis. So this is the problem that may have happened. So these babies may also suffer from acute blood loss, severe antenatal or peripartum intrapartum blood loss due to hemolysis. Massive fetal-maternal transfusion or blood loss during preeclampsia may be the cause of perinatal asphyxia. How do we manage? How do we manage babies with HIE? So the principle of management, the first thing is clinically stabilize the baby. So if the baby has problem with breathing, you stabilize breathing. If the baby needs just respiratory support with CPAP or high flow nasal cannula, so you give high flow nasal cannula. If there is problem maintaining the airway, so you intubate the baby. If there is a poor respiratory effort, so you give ventilation by mechanical ventilation. If the baby needs cardiac support by inotrope, so you provide inotropic support. So basically clinical stabilization. If there is blood, there is anemia, you give blood, you give fluid, and so on, so forth. So stabilize the baby clinically. Again, A, B, C, D. And then evaluation to establish extent of end organ injury, liver, GI, kidney, and so on and so forth, and identify the underlying cause if it is treatable. So for example, if it is a metabolic disorder, so identify and treat the metabolic disorder. If the problem is actually cardiac, for example, so treat the cardiac cause. So and then maintenance of adequate ventilation, as I mentioned before, and avoidance of hypoxia or hyper and hypocapnia. So you don't want the CO2 to be high, and you don't want the CO2 to be too low. If the CO2 is too low, then you may impair the blood supply to the brain as well. So maintenance of adequate tissue perfusion. So BP control is essential as well. Again, for example, if they have PPHN, so the pulmonary blood pressure is high. If the systemic blood pressure is low, then there will be impact in terms of perfusion, in terms of oxygenation. So you need to increase the systemic blood pressure. So seizure control. If there is seizure, then there may be reduced and diastolic volume, for example. If there's seizure, the baby may not breathe well. So you need to control the seizure. And again, cerebral edema is an issue. So we need to treat cerebral edema. We need to reduce cerebral edema and so on and so forth. Correction of fluid, electrolyte, and metabolic imbalances. Glucose may be abnormal. Sodium, potassium may be abnormal. Calcium may be abnormal. So we need to correct all of these. And if there is renal impairment, if there is oliguria, sometimes, many times we actually need to fluid restrict as well. So reduce the fluid that we're giving to the baby. So what are the investigation? We send blood gas analysis. Again, we may see pH, low pH, pH of less than 7.0, for example, by low bicarb, high base excess, high lactic acid, high CO2, high low O2, for example. So these are the things that we need to see. Full blood count, again, whether there's thrombocytopenia, whether there's anemia, and then glucose level as mentioned before. Renal function test includes calcium and magnesium as well. Urea, creatinine, electrolyte, urea, creatinine, sodium, potassium, calcium, magnesium. Liver function studies. So we look at the AST, ALT. ALP is usually more of biliary tree, so it's not that important. So, but mainly is AST, ALT, and gamma GT. And the cardiac evaluation, echocardiography is actually very, very, ECG is very, very important. ECG, echocardiography, and also the cardiac enzymes such as CK and so on and so forth. So infectious disease evaluation, blood culture, septic workup, send for CRP, troponin, for example, and cranial ultrasound, because sometimes they may have bleeding inside the brain and they may have intraventricular hemorrhage. So what are the further investigations? So we may send several further evaluation based on the clinical status, clinical condition of the baby, chest x-rays, abdominal ultrasound, cardiac markers as mentioned before, coagulation profiles, IEM screening if the baby has persistent acidosis, for example, high ammonia. So supportive care are basically wholesome lah. Cardiovascular, respiratory, fluid, nutrition, glucose, hemostatic management, drug monitoring, jaundice, infectious disease management, neurological, renal, and endocrine. So all these are things that we need to do. Nutrition, for example, sometimes we may need to start on TPN. total parenteral nutrition. But if you want to give TPN, you may need to put a central line. So how do we monitor? Ideally, we should have electroencephalography, EEG, not just the usual EEG yang kita buat in bigger children or in adults. EEG biasa kita pasang dan kita tengok the brain wave macam tu saja. But what we want is AEG ataupun we may call as CFM, cerebral function monitor. So this is a bit we just look at the electrical charges in the brain. So it's similar like the typical EEG, but we put it for several days, for 3-5 days, for example. We need to monitor the vital signs closely and include glucose as well as part of the monitoring. Okay, this one many center do not have. Blood investigation quite frequent. Daily cardiac ultrasounds. So sometimes the bleeding, it can go from no bleeding until suddenly grade 2, grade 3 IVH. And this is the thing that I've been talking about, therapeutic hypothermia. So to treat HIE, to reduce the effects of HIE, to prevent it from going into a secondary delayed phase where there is cellular apoptosis. So we may start therapeutic hypothermia. There is ample evidence suggesting that therapeutic hypothermia is actually useful and has better neurological outcome. So how do we do? So we use this only for moderate to severe HIE. Mild, there's no use for mild. So how? Infant with pH of less than 7.0, or base base excess of more than 16. So and then moderate to severe encephalopathy, or babies that needs ongoing resuscitative efforts, ventilation, and so on and so forth. This must be done in care in center with expert. So how? So these are the flow chart. So whether they meet criteria for hypothermia, and we commence cooling. So the temperature we want is 33 to 35 lah, 33 to 34. So we maintain temperature, rectal temperature 33 to 34, axillary temperature 33.5 to 34.5. So this is what we aim. So how we do? So sometimes ideally we should have an active cooling machine. Sebenarnya dari satu machine, kita balut baby in that machine. The machine will gradually reduce the baby's temperature and then maintain accordingly. Sometimes kita ada juga center dia guna ice. Biasanya kita letak ice dekat body baby, kita letak ice dekat kepala baby. Cuma problem with ice ni, kita susah nak control dia punya temperature dia. Susah nak control temperature dia. Sebab ice punya temperature, we don't know kan. So it's near zero pun. So macam mana nak reducekan temperature properly? So that's the problem. Sometimes kita just, because our NICU ni, the aircon is quite cold. So passive cooling is when macam mana kita just open the baby, tak pakai baju, just pakai nappy, do not start any warmer and leave the temperature to cool down by itself using the environmental temperature dalam NICU tu. Again, but this is not ideal lah. Okay, and then how do we rewarm? Bila cukup, so we cool the baby for 72 hours. Untuk 3 hari, 72 hours. And then we rewarm the baby gradually over 12 hours. So kita naikkan by 0.5 degrees Celsius every 2 hours. Tak boleh cepat sangat. Cepat sangat pun boleh cause reperfusion injury as well. So what are the side effects or complications for cooling therapy? So the baby may have sinus bradycardia. Why? Because the temperature is low. So cardiac respiratory rate pun akan heart rate pun akan reduce. So the baby may have sinus bradycardia. So do not be too worried. There may be decreased blood pressure. Decreased blood pressure as well. So but this decreased blood pressure is usually transient and reversible. So we are not that worried. But sometimes they may need inotropic support as well. They may need more oxygen requirement, especially bila kita tengok dekat SpO2 saja. So we may need more oxygenation. There may be mild thrombocytopenia as well. This is a known complication of cooling therapy. There may be increased bleeding tendency as well. So these are all probably liver punya effects. And certain drugs are not metabolized well in low temperature. Morphine, for example, phenobarbital, for example. And too rapid rewarming, kalau kita buat less than 12 hours, ataupun the increase is more than 0.5 degrees Celsius over 2 hours, sometimes what result is you may cause peripheral vasodilation, hypotension, and reperfusion injury. So prognosis is directly proportionate to severity of the HIE. As mentioned before, mild HIE usually very good prognosis. They don't have any neurological sequelae. But moderate to severe usually have some, moderate at least some element of neurological sequelae. But severe HIE usually have significant neurological impairment, neurological sequelae. What are the predictors? So severity of the condition, and then return back to actually among the function that shows good prognostication is actually sucking and Morus reflex. The faster the child can able to suck and swallow, it suggests that better prognosis. It suggests better prognosis and less neurological sequelae. So MRI finding, we can see abnormal signal in the posterior limb of the internal capsule. And then seizures, EEG as well, good clinical predictors. And there are the biomarkers which are actually very difficult for us to send, NSE, interleukin 6, interleukin 1B, and so on and so forth, which basically are only used for research, not available yet. Okay, all right, I think that's it. Any questions? Kita tidur belaka dah. Clear? Faham? So again, you don't need to, there's no need for you to actually remember everything about birth asphyxia. Obviously, you won't get babies with birth asphyxia with HIE in exam, either in your block exam. Definitely, you will not get babies with HIE. In professional exam also, you won't get any babies with HIE. But what you will get in your exam, in your clinical exam, block exam or professional exam, especially block exam kalau kita buat style modified long case, where we call the patient from home, is that you may get complication, babies who have complication from HIE. For example, babies with cerebral palsy, cerebral palsy. So, cerebral palsy is among the major complication of major result of HIE. So you may have babies with cerebral palsy. Again, we have loads of patients with cerebral palsy. It's so easy to get patient with cerebral palsy to call for your exam. Usually kalau patient macam last minute patient cancel pun, the easiest for us to call is actually cerebral palsy patient. So they can come easily. They are used to the hospital. They know where we are. We have loads of patients from many departments as well. So it's so easy for us to call them for your exam. There's so many things to ask. We can do neurological assessment. We can do developmental assessment. There's so many things to discuss. And the thing is, many students fear neurological punya station. The moment student nampak patient tu macam neurologi je, main ketor, kan? Padahal if you understand how to do neurological examination, it's actually very easy. It's actually easier than cardiovascular examination if you understand how to do it. In that sense, you can siapa group yang ada masa lagi, you can ask me. If we have time, we'll discuss how to approach neurological examination, how to approach cardiovascular examination, how to approach respiratory examination. If we have time lah, we can arrange with me. If not before block exam pun, at least before professional exam. We can discuss. Remind me if you want. Tak nak, tak apa, tak ada hal, no problem. So that's the thing. So it won't come up in HIE will not come up in your block exam or professional exam, but you may get babies or children with complications of HIE, which is cerebral palsy. But HIE also can come in your block exam. So we may ask you questions about conditions that may result in hypoxic ischemic encephalopathy. So we can ask in PMPs and so on and so forth. We can ask in theory exam, for example, in MCQ, and so on and so forth. Okay, all right, fine. Any question? Faham belaka? Tidur belaka?
Doctor, I would like to ask a question. So regarding the complication of HIE, for example, this patient dia ada severe HIE, and can we terus diagnose dia as CP or we need to wait until 3 years old?
No. CP, the earliest you can diagnose is after 2 years old. Why? Because CP is in a developing brain. So maknanya masa dia tengah developing tu, you cannot diagnose CP. The maximum you can do, sometimes certain babies we know already the baby is CP. So what we do is we label as evolving cerebral palsy. Sebab you don't know the outcome until at least 2 years old. So after 2 years old, only you can label a baby as cerebral palsy. Before that, the maximum is evolving cerebral palsy, evolving CP.
Okay. So meaning if it's just mild, so it can be reversible, right?
If mild HIE usually within 24 hours settle lah, tak ada apa-apa dah. Less than 24 hours, few hours sometimes dah okay dah baby tu.
Okay, thank you, Doctor.
Any other? Tak ada? Clear dah? Alright. Okay, that's it. If there's no other questions, 50 minutes, that's good. I think teaching lama-lama pun tak bagus juga, kan? Just enough is enough. Alright, okay, let's end our session with tasbih kafarah and surah As. Okay, Assalamualaikum.
Thank you, Doctor.
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 Assalamualaikum.
Waalaikumsalam.